As an osteopath these days, I see many cases of shoulder pain, shoulder injury is in a large range of the population, so it's not specific. It could be just a bit of stiffness on movement, a discomfort at the end of range, or general pain on pressure, or all kind of movements as well. So today I'd like to see how the anatomy of the shoulder works and how we can link it to us being predisposed to any kind of shoulder pain. One of those factors, we'll talk about it after, is posture. And our generation tend to adopt more easily a poor posture or posture will affect us to change our structures. And those structures will become in a dysfunction state. That state is what we're going to talk about today, and how shoulders are more affected than any other part of the body concerning those dysfunctions. In order to understand how we are so affected by shoulder issues, we would need to review a bit of anatomy. So first of all, the shoulder is what we call a ball and socket joint. It means that there's two major articulatory surfaces making up the joint. And another joint that is built like this is the hip joint. However, the difference between the hip joint and the shoulder joint is that the articular surface of the shoulder is way more shallow, allowing way more mobility. Unlike the hip, that requires more stability as we are weight bearing on both hips. This is why the shoulder is, first of all, quite prone to injury because of that excess of mobility that we have. The more mobility we have, the more stability we give up. So the shoulder joint is composed of three different bones: the humerus, the arm bone, the clavicle, also called the collarbone, and the shoulder blade, also called the scapula, just there. Now we're going to see how that very mobile joint, as we say, can allow itself to keep a minimum of stability. So we have three major ligaments wrapping around the joint, and all of the ligaments linking the collarbone to the humerus, shoulder blade to the humerus, and all together. But what are going to be the main structures stabilizing this articulation is actually the muscles. Among the 17 muscles that attaches on the shoulder blade, there's 4 of them forming a group of muscle that are going to be mainly responsible for that shoulder stability. We call that group of muscle the rotator cuff. Those rotator cuffs will have 2 different functions. First one will be to achieve rotation in the shoulder joint, so external rotation and internal rotation, as well as keeping a minimum tension on the humerus. So 2 of those muscles are going to pull in from the upper part of the shoulder, and 2 others are going to pull inferiorly that bone. Like this, that tension creates a certain stability of the humerus head staying into the fossa of the shoulder blade. Now, in case of poor posture, those muscles are going to be put under a lot more pressure and will easily be overloaded. And we'll see how that becomes problematic. 2 of the rotator cuff, the supraspinatus, who's on the superior part of the shoulder blade, and the subscapularis, who's on the internal part of the shoulder blade, are going to be put in relatively high tension in case of a poor posture. This is what we call an upper cross syndrome, when we have that increased flexion, also called kyphosis, in the thoracic spine, as well as that transitional internally rotated posture in the shoulders. So the shoulders are naturally going to rotate in as the upper back flexes. That causes the chest as well to be compressed and all the pectoral muscles to be shortened. That problem engenders the fact that the 2 muscles here that are supposed to maintain that head of the humerus inside the joint are going to be put into much more tension. They're going to have to do the same function while being stretched even more. Over time, if that becomes chronic, as a poor posture would be, this tension will engender an inflammation in the tendon of those 2 muscles. This inflammation will generate burning sensation on a continuous level, especially on the activation of this muscle, so during rotation movement. But it will also cause the swelling of those tendons. And with this swelling, the shoulder joint will have less space to move, and it's possible that that decrease in space creates more acute and sharper symptoms on the head of range. As the bone fully open, for example, or fully flex, we will compress against that swelling, inflamed situation, and this will create sharper pain. Now, if we face this way, we can also see that compression occurs anteriorly in the shoulder. That simple fact of compression over time, and for example, more active people, more athletic, that compression can also be problematic and create an inflammation in the junction in between the collarbone and the shoulder blade. If that position is maintained, and if those little inflammation are maintained, not only they will become more important, but the muscle will naturally get weaker and weaker as well, as they can't fulfill the function they are required, as it's not adapted to the original structure of our posture. Therefore, in those cases, the muscle becomes in a state of constant tightness, and there's some ways we can identify that tightness before it gets too great, that the inflammation will transfer into tendinitis or a way greater injury, like a dislocation or subluxation. Those kind of injury can happen if the muscles are maintained in an overloaded state for too long, and therefore they will give up, they'll become weak, and the mobility of the joint will become so great that under certain pressure and misangled movement, the shoulder joint can dislocate and or subluxate. What we're going to talk about now is the few little tests that will help us to identify those little tightness before they become what we call a pathology, a condition, a musculoskeletal dysfunction. After that, we'll see with a colleague of mine how we can manage those tightness and how in the future we can anticipate becoming part of that dysfunctional state. So the first test we can do is just see how the ranges of movement are. So in the shoulder complex, we have three main movements. First one being flexion with a pronated or supinated hand up to 180 degrees and come back. Second one would be the antagonist movement, so extension and come back. And the last one being abduction and come back. If there is a presence of supraspinatus tendinitis or subscapularis tendinitis, or a presence of a bursitis, for example, little cushion structure that we have within the shoulder in different spots, if those are inflamed, they will swell, and if the supraspinatus has a tendinitis, the tendon will also swell, and we will reach more or less from an angle of 40 degrees to 120. This arch in the middle will necessarily be symptomatic. There will be also a feeling of instability and a feeling that we can have this feeling that the arm bone, the humerus, is not properly angled into the shoulder. Another test to identify some sort of inflammation in the capsule of the shoulder from whatsoever structure, we can do the empty can test. So you're going to put your arm like this at 90 degrees with your thumb up, rotate, and just ask someone or use a structure to push against towards the top vertically. If there's any symptoms within the top of the shoulder or on the side, on the deltoid area, it's likely that there's a decrease in the space of the shoulder joints, so much that full range are not achievable and that the bone are hitting against inflamed structures. Another test we can do is to identify the inflammation of one of the rotator cuff, the subscapularis, one of the major rotator cuff muscle responsible of the stability of the joint. So place your arm like this and just ask the person to hold you and try to put back your arm to a neutral position. On that contraction, if there's pain, it's likely as well that the tendon of the specific concerned bone is also in an inflamed state. Once we've understood how we predisposed and how we expose ourselves to be in pain in the shoulder area, what's important is to be able to identify those specific structures that are affected. If the problem has been maintained for too long, it's likely that the structures have also been influenced by that abnormal period. If that became chronic, it's likely that manual treatment will be needed in order for structures to be readapted to a normal posture. If not, the muscle will still be able to be assessed, either on the short term by stretches or other physical rehabilitation, as well as reinforcement. As we said, if the problem is maintained for a long period, it's likely that the muscles have entered into a weaker stage, and you will need to reinforce those muscles in order to regain full capacity of stability in the joint. Now that's what we're going to see with a professional trainer who will help us specifically to train the areas needed in those specific situations.
Hi, my name is Nate and I'm from EPT, and I'm the trainer that will be able to support you in rehabbing your shoulder injury after you've got a green light from our osteopath or our physiotherapist. Now, as you may have already seen before, a big part of the shoulder problem is like because they're kyphotic, which is a rounding of the shoulders at the top here. So what we're going to be looking to do on my part is to be able to basically strengthen all the muscles through the back, stretch all the muscles through the front, and increase or decrease this curvature so that way she comes up a little bit taller, so that way there's less pressure on the shoulder joint. And I'm going to show you that now. All right, so the first one we're going to do is we're going to create some mobility through her thoracic spine. And how we're going to do that is in each vertebrae, there is obviously there's a disc. And what we want to do with that is actually create a little bit of movement between each vertebrae, so that way we can create a little bit of mobility in that spine. So when we start doing the strengthening exercises and as well as the stretching exercises, we can actually get a lot more movement in there to create a correction. So I'm going to get her to lie down on her back, so that way you can see what we're going to do. So where she's going to start pretty much near the base of the neck. She's going to support her neck with her hand, and she's going to exhale as she goes back over the foam roller there. And she'll hold that just for 3 to 4 seconds. And then when she comes up, she inhales and she pivots just on that point where the foam roller is. And then she'll exhale when she goes back again. She'll do that 3 or 4 times. And then what she's going to do is she's going to move herself up a little bit higher that way, just a little, just so that way she can do the same thing again on another vertebrae. So that what we do is we create that movement or mobility between each joint. Okay, now the next one I'm going to get you to do is when we have tight through the neck, through the shoulders, we get tight through our neck. So what I'm going to demonstrate is just a couple of neck stretches to be able to alleviate some of this pressure, because when we alleviate the pressure from here, we actually start to pull the shoulder blades back. Our head weighs around 10% of our body weight, so it is a lot of pressure on that shoulder joint. So here's what we're going to do. Turn around and face the screen. So what she's going to do is she's just going to sit on one hand, sit up nice and straight, sit on one hand, and then she's going to grab the head and just gently pull it over to the side here. And she's going to get a bit of a stretch through the sternocleidomastoid, which, like I said, is one of those muscles that'll pull her head forward and put pressure on a shoulder joint. So we want to be able to stretch that. And you're going to hold this around 5 to 10 seconds. The deal is that with the neck, there's not a lot of spindle fibers in there. So we don't want to hold the stretch for too long. Change sides. Now you'll find maybe one side tighter than the other. Generally the side that's tighter is usually the side where we've got the shoulder issues, but not always. So just be wary that if you are tighter on one side, you want to do a little bit more stretching on one side more than the other. Okay. Now, another neck stretch that you want to do as well is you want to do a levator scapula. So she'll place one hand up over the top of the shoulder. She'll grab hold of her shirt. She'll be able to tilt her head just on an angle here and then just drop the head forward on that angle, and then she'll start to stretch through the neck. Now, if you do feel a pain through that shoulder, what you can actually do is you can drop that shoulder down, keep that head on that angle there, grab the back of the head with the hand and just gently pull it down on that angle there. And now change the other side. It's like as if you're tilting down and you're trying to smell your armpit. That's where you want to get it. All right, so the next one you want to be able to do is you want to stretch to the chest, because generally the pec major and the pec minor are tight when that shoulder joint's tight as well. So what I'm going to get her to do is I'm going to demonstrate a chest stretch so that way we can really stretch through those joints. So she places her hand on top of the ball. She just gently drops her body down towards the floor. And then as that shoulder goes past the elbow, you'll find that she'll start to feel that stretch to that shoulder joint. Feel that stretch?
Yes.
Great. Okay, now you can also play with it a little bit as well, where you can just glide that shoulder, that elbow up towards your head, and that may increase the stretch. But just be careful, we don't want any sharp pain. All we want is a gentle stretch there. And then what you'll do is you'll just repeat on the other side. So you've got to remember there's 3 things that you need to do when you're rehabbing your shoulder. There's the first one, you need to be able to get mobility through that shoulder. The second one, you want to get flexibility through it. And then the third, you want to build strength. Now, once we've built that flexibility and mobility through the shoulder joint, now what we want to do is go into that strength component. And I'm going to show you a couple of exercises now that will be able to strengthen that shoulder joint. The first one we're going to do is an upright row. Now, very different to the normal bench press and the bodybuilding upright row. You'll find that the elbows will only go up to shoulder height. So go on, I forgot. It'll only go up to here. Shoulder blades down, chest up nice and proud, and posture is super important. Drop it back down again. And as you notice, bring it back up again, you'll notice that the elbow is also not putting a lot of pressure through it. The dumbbells are in, they're out rather than in. Okay, drop it back down again. And you'll notice the shoulders as you go up. Go up. You'll find that the shoulders will shrug up a little bit. You want to be able to keep them down as much as you can. Okay, so the next one we want to be able to do is we want to be able to strengthen the rotator cuff. Now, there's 4 muscles in the rotator cuff, and what we need to be able to do is get a balance between those. Now, the rotator cuff goes in and it goes in outwards. And I'm going to show you a couple of exercises that you're going to be able to do to be able to strengthen that rotator cuff. Now, the first one we're going to do is we place that just underneath her armpit. And then what you do is you grab hold of the handle. And then from this position there, she'll rotate her hand outwards, meanwhile, keeping that towel underneath her shoulder there. And it doesn't drop out. She'll just rotate that out as far as she can, but making sure the towel stays there. Now, the next one is going inwards. Going around, and what you'll do is she'll rotate the hand inwards as opposed to going outwards. That is strengthening her other parts of the rotator cuff, so that way we can actually strengthen on both. Now, bear in mind, with the rotator cuff, it must be balanced. In other words, it must be even. Even though that this generally is stronger with most people, it's got to be the same strength as this way, as well as going outwards. So your final exercise that I'm going to show you is a lateral raise. And the idea is to be able to build strength through the deltoids, through the medial deltoids. And how are you going to do that? Bear in mind though, is if you do experience pain, operate within the pain. As in, if you experience pain at this height, take them a little lower, okay? And then you work through that. So the goal of this exercise is to be able to make it all the way up to here. If there is no pain, then you turn your hands over and then you start bringing them all the way up to the top. And if you still don't experience pain, you get them to the top and then you come back down again and then you turn it over and then you bring it back down again. Now, bear in mind that if you do feel any sharp pain, work within that pain. So as I said, if you feel pain up here, then what you'll do is you'll lower it a little bit so that way you don't experience pain, but those muscles will start to build. And then after about a 4 to 6 week period, you'll find that you'll be able to go higher than what you were be able to go before, which is what we're trying to do. We're trying to get the full range of motion through those shoulders, build on those shoulders, and also, we also want to be able to get those scapulars moving at the back here as well. Okay? So, for any more details or any more information that you need, then just post below and then I'll be able to support you and be able to give you the right rehabilitation program for your shoulder. Thank you for watching. My name is Nate and I'm from EPT.